we can, 32 people
Okay,
have joined.
Okay. Acha, just a little bit of a preliminary introduction. I just want to say a couple of things that we are starting your neonatal sessions, right?
Yes, ma'am.
And before before doing all these clinical case presentations, you were supposed to have a class on physiology and pharmacological, all related to neonatal considerations for anesthesia, right? Apart from the
Yes, ma'am.
physiology. So that class has not been done. Okay. So I'm hoping that you are all now in third year. You have all been experienced in doing neonate. So somewhere you will have a basic idea because we cannot cover that part. That is not in the scope of this discussion today. Okay, so we presume, and this class will happen for you on 13th, I think, isn't it?
Yes, ma'am. Till now, we haven't been told the date for
Yes,
neonatal
as
physiology.
far as I know, it's 13th.
Okay.
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 So we'll start now, but unfortunately, I really wanted this class to be done after because we are not going to be discussing very basic things about neonates like temperature monitoring, physiology, drug pharmacology, sugars, okay, blood transfusion protocols. We are not going to be discussing all this today. We are going to stick to TEF and CDH. है ना? Okay?
Yes, ma'am.
All
Okay.
right. Chalo, Himlata, shall we start?
Yes, ma'am.
Okay. How many are there? 16 only, 17. Okay. Too bad.
Uh,
It says guests waiting to join. Why are they not joining?
मैंने कर दिया है, जितने लोग दिख रहे हैं उनको तो ज्वाइन.
ठीक है. All right. Let's start, Himlata.
Okay. Good afternoon, everybody. Today we are going to discuss two cases. First is tracheoesophageal fistula and congenital diaphragmatic hernia. TEF will be presented by me and CDH will be presented by Dr. Ira later on. This whole class is moderated by Dr. Charu ma'am. Thank you, ma'am. So let's discuss. So my patient is a 3-day-old neonate girl, product of non-consanguineous marriage, born to a 34-year-old lady, Mrs. Sajida, resident of Haryana, born at 10 p.m. on 27th of July and admitted to Safdarjung Hospital on 29th of July. Informant is father and reliability is limited. Maternal history and family history. There was no history of any comorbidities in the mother. There's no history of any congenital anomalies, hearing impairment, or mental retardation in the family. Coming to the obstetric history, she is a para 4, live birth 4, and abortion 0. There's just one important history in this obstetric history. The first child was a preterm baby who was born via normal vaginal delivery. He was later on admitted in the nursery. He was given oxygen and given kangaroo mother care and was discharged later on after 18 days in a healthy state.
Why is this history important? 1 second, Hemlata. Why is this history important? Go to the previous slide. Sorry, the next one. This one. Why is this history important?
Ma'am, there is a chance of...
no, let's put somebody else. Arvindan, why is this history important? What she has said, no history of congenital anomalies, mental retardation, whatever she has said, no comorbidities, and the first child history she has given. Why is this history important in a neonate?
Ma'am, like if there is something in the previous child, then it can also be present in the this child also.
No, that is not necessarily true. I mean, that is not the reason. Have you read income? Read income. Anybody else?
Ma'am, consanguinity may cause a lot of congenital anomalies.
Yeah, that is taken. That is taken. Anybody else? Why is this important history? Congenital anomalies in the baby, in the family. Why is this important? Sakshi, Rohan, whosever name I can see. I don't know who this M and the anesthesia. Sakshi, bolo.
Ma'am, first of all, that gives us an idea about the tendency to, ma'am, like if one sibling has a disease, there is a possibility of that disease to recur as compared to a sibling not having the same disease.
Give me an example. What disease should a sibling have that tends to recur in another sibling?
Ma'am, Down syndrome,
Down syndrome.
cardiac anomalies, and ma'am, even TEF has a higher uh, occurrence in siblings as compared to somebody whose sibling does not have a TEF.
Basically, now we know we are talking about test, right? But even if you talk about any other congenital surgical anomaly,
Yes,
then
ma'am.
it is associated with some small amount of familial association. Okay, that is what you say. You know, and
Yes, ma'am.
second thing is 10 to 15% of these cases are associated with chromosomal
Yes,
anomalies.
ma'am.
Okay,
Chromosome.
that is what it's pretty simple. I was expecting it's a very simple, straightforward answer. Okay, okay,
Yes.
Himlata, let's move on.
The rest three children were normal. They are all alive and healthy, and they are all male child. Now coming to the present.
Female child has the death. Mhm. Yeah.
Coming, yes, ma'am. Coming to the present pregnancy, a mother was a booked case, spontaneous conception, which was confirmed by a urine pregnancy test on missed periods. There's no history of preconceptional folic acid intake. Her LMP was 18 November 2020, and
Why is
expect,
important? No history of preconception of folic acid.
ma'am, to rule out neural tube defects, ma'am.
Yeah.
It is
Yeah, it is given as for prevention of.
neural
Yeah.
tube defects, so it is
Okay.
a prophylactic. And her expected date of delivery was 25th of August 2021. First trimester was uneventful. Ultrasound was done at 12 weeks. She was given folic acid as soon as the pregnancy was confirmed. Routine investigations and viral markers were done. Now, all these investigations are happening in Haryana. She was later on referred to us. So, I didn't have the documents regarding each of these. No history of any excessive vomiting, bleeding for vagina, spotting, radiation exposure, fever with rash, alcohol or tobacco intake, any medication or excessive vomiting.
Okay, okay, yeah.
Second trimester, the fetal movements were perceived at 20 weeks of
Okay, so
gestation.
everything is okay in
Yes, ma'am.
second trimester. Third trimester.
The third trimester history is important. They got an ultrasound done, which suggested polyhydramnios, and she started having labor pain at 34 weeks of gestation at home. Now, this 3-day-old neonate with the diagnosis of esophageal atresia with tracheoesophageal fistula was scheduled for TEF repair and who presented to the hospital with the chief complaints of frothing from mouth since.
Basically, the child came with this symptom and she was admitted to surgical ward, and where they diagnosed her, or the neonatologist diagnosed her as a TEF.
Yes, ma'am. And yes, ma'am. Not passing stool since birth and difficulty in breathing after 2 days of birth. This is a picture showing the frothing from mouth. I just wanted to incorporate it. Now, history of presenting illness. There is no history of any bluish.
Just one sec, Himlata. Anybody
Yes,
has
ma'am.
any questions? I mean, I was very curious. You said first 3 children, male children, all normal. This female child. What is the predilection? Male, female?
Ma'am, there are more cases reported in the males as compared to the females, but ma'am, but in India, that might be due to the female negligence also. So,
No, this is the worldwide data of female.
Yes, ma'am, the male preponderance, yes, ma'am.
Okay, so this is the picture of the baby.
Yes, ma'am. Frothing from mouth. Now, history of presenting illness. There is no history of any bluish discoloration during crying, no history of repeated vomiting, swollen abdomen, no history of any bluish or yellowish discoloration of the skin, no history of any limb abnormality, no history of any large size head, weakness in any limbs, no history of any facial deformity, severe chest indrawing, or any abnormal body movements. Now, coming to the natal history, this girl was born on 27th of July at 10 p.m. at home by Dai. She cried immediately after birth. No history of any resuscitation at birth, and no history of any meconium staining of the amniotic fluid was present. Birth weight was 1.6 kgs. She was breastfed after 2 hours of birth. She passed urine after 1 hour of birth, and stool was passed in this hospital at 11 p.m. on 28th of July. Immunization history, the baby
Did you
was
say
immunized.
previously she didn't pass through?
Yes, ma'am. The father gave history that she didn't pass stool at home, but in the documents it was written when she was
Okay.
admitted in surgeon,
All
she
right.
passed. Yes, ma'am. And, now we will come to the examination of the baby. The baby was
We'll just
examined.
we'll hold over here, Himlata.
Okay,
Okay.
ma'am. Yes.
So, Himlata, what is the incidence of this is a baby you got with a diagnosis of tracheoesophageal fistula, right?
Yes, ma'am. Yes,
And
ma'am.
they have come for
The
surgery,
repair. Yes, ma'am.
for repair. So, what is the incidence of death?
Ma'am, the incidence is 1 in 2,500 to 3,000 live births.
So now what happens is that we don't have our own data, right?
Yes, ma'am.
And so we go by international data.
Yes, ma'am.
Okay, one question I want to ask, guys. You all come to NEB, right?
Fine.
All of you have had exposure to NEB. What is the type of surgical emergency, which is the patient profile of surgical emergency, which is the most common? It's a neonate, okay? In now I don't have data for 2020 and 2021. The reason is obvious because of COVID. But in 2019 we did the audit and we had 300 neonates, 301 to be precise. Okay, in 2019. So this is the profile of patient you are going to face most commonly. Okay, and out of this, which is the most common surgical finding? Hemlata? Out of the 301 neonates. Ajay, what are the emergencies you have seen in neonates?
Ma'am, I have seen perforation, peritonitis, I've seen appendix,
Neonate.
anal,
Neonate.
ARM, anal malformations.
And
Then I have never seen congenital diaphragmatic hernia. I have seen a lot of tests. Then
so out of these, TEF is the most common. That's
most
what
common.
I'm saying. So you guys have to know this very well. Huh? How to
Okay.
manage. So Rohan is there?
Yes, ma'am.
Rohan, what's the classification types of TEF? Do you know?
Yes, ma'am.
No.
Ma'am,
I would
the
have liked
classification.
actually a picture of this. Hemlata, do you have a picture? I'd asked you to put a picture. Do you have it?
And that X-ray picture.
Not X-ray. I want types of classification of TEF. Chalo,
No.
ab bolo Rohan.
Ma'am, the classification for TEF was given by Gross and Watt, and they divided it in 5 types. Type A, B, C, D, E. In type A, ma'am,
Who is they? Who is they?
Gross and Watt classification.
Gross and Watt is one classification. बुक
Yes,
खोल के
ma'am.
अभी पढ़ रहे बेटा तो ऐसे ही होगा
नहीं, ma'am.
चल रोहन Ross and Vogt is not like Simon and Garfunkel or something. Ross is one thing and Vogt is one thing. Okay, so their classifications are different. So tell me about Gross.
Ma'am, they divided the TEF into 5 types. Type A, where the proximal and distal end of the esophagus both were blind.
It's called a pure esophageal atresia.
Yes, ma'am. In type B, the proximal end of the esophagus is connected into the trachea while the distal end is closed. In type C, which is the most common type we see, in which the proximal end of the esophagus is a blind pouch and the distal end of the esophagus is connected to the trachea. In type D, the both proximal and distal end are connected to trachea, but they are not connected to each other. And type E, both of the ends have a common site of junction, and then they are connected to the trachea. It is also called as type H.
Okay, so you said that type C gross is the most common, huh? 85%.
Yes, ma'am.
Right?
Yes,
This
ma'am.
corresponds to Vogt classification. What type?
This class 3, ma'am.
3B.
2B.
3B.
3B, okay.
Okay. So now you read your classification properly. It's better if you read and come because for whatever reason, TEF में classification जरूर पूछते हैं. But
Yes,
you
sir.
have to know which one is commonly seen and which one is very, very difficult to diagnose. Which is difficult to diagnose? I can't hear whoever's speaking. Speaking, I can't see.
2.6 year old
I can't hear.
or 2.6 plus
It's not
25.
Poonam, I think you need to
पूनम का
mute.
मेरे को बिल्कुल सुनाई नहीं देगा.
Yes, ma'am.
चलो, पूनम is there. पूनम, can't hear. Who's this MD anesthesia? जिसका लिखा है identification, MD anesthesia. M लिखा है. अच्छा, हिमलता, let's not waste time. हिमलता,
Yes, ma'am.
हिमलता, थोड़ा सा
Yes.
embryological origin बताओ टेस्ट का.
मैम बेसिकली हमारे जो this both trachea and esophagus, they arrive from the foregut, and this foregut arises from the primitive endoderm. Now subsequent eventually these this thing differentiate into trachea and esophagus, and they develop from the pharyngeal arch 6 at the level of the lung bud. So बहुत सारे growth factors से this anterior foregut develops into the trachea and lung tissue, and the posterior portion it develops into the esophagus. लेकिन जो because of the errors in separation, there are from of the trachea from the foregut, that's why there are residual fistula and atresia formed between the trachea and esophagus.
Vandana, Vandana is there?
Yes, ma'am. Yes, ma'am.
Vandana, what is Vater anomaly and vectoral anomaly? Tell me about the association.
Ma'am, vector and there are vector anomalies. These are the anomalies associated with TEF, ma'am. It consists of consists of vertebral arch defect, ma'am, and A is consist of anorectal, and C is consist of cardiac anomalies, and T is tracheoesophageal, and R is renal anomalies, ma'am, and L is limb abnormalities.
And what is Vater? What is the difference Vater and vectoral? Basically,
Ma'am,
now I'm just telling you. So why are we going through this acronym? Because you have to look for these associated conditions when a baby of TEF is brought to you.
yes,
Okay?
ma'am.
Which are the common cardiac anomalies which are associated?
Ma'am, cardiac anomalies, mostly atrial septal defect, ventricular septal defect, and persistent patent ductus arteriosus, and tetralogy of palate. This all will be associated with tracheoesophageal fistula, ma'am.
Anjusha. Anjusha there? Anjusha.
Yes, ma'am.
Anjusha,
Yes,
how
ma'am.
will you diagnose, how is a baby of TEF? How do you diagnose? Antenatally, postnatally?
Hello.
Can you hear?
Yes, ma'am. Can you please repeat the question?
I said, how do you diagnose a baby of TEF?
Ma'am, clinically,
Postnatal.
postnatal,
Antenatally and postnatal.
postnatal, clinically, the baby will be presented with frothing and increased salivation and choking, and they will be unable to pass the nasogastric tube beyond 10 centimeter. And we can also take a chest X-ray, which will be diagnosed as a presence of that nasogastric tube in the blind pouch.
Okay. And sometimes there's gas because through the fistula. Okay.
Yes, yes, ma'am.
And sometimes a patient presents with pneumonia. When they've fed the baby and they have not diagnosed it, sometimes they present with pneumonia. Okay.
Yes, ma'am.
And antenatally?
Antenatally and USG, there will be most probably polyhydramnios will be diagnosed, which is associated with TEF. And otherwise, TEF is very difficult to diagnose clinically.
Yeah. When when do you operate these babies, Anjusha? Is it an emergency?
Ma'am, if the patient is having a respiratory distress and all, it can be surgically treated in within days itself. But if the baby presented with the sepsis, aspiration, and chest is bad, we can delay the surgery with primary repair of cervical esophagectomy and gastrotomy, and second stage can be repeated after that all the infection and sepsis has been subsided.
Okay, so what you're saying is if the baby's condition is good, then you can go for a primary repair at that time, in which you
Yes,
do a ligation, fistula, and approximation, right? And
Hmm.
if the baby is sick, then you have to first improve the
Wait,
condition, then bring them.
then wait.
Okay, but what I'm trying to say is that these are to be operated urgently, but they are not life threatening. Okay, so it's not that they have to be done absolutely hyper urgently, but they have to be done as early as possible. Okay. Now who's Ankush?
Yes, ma'am. Good afternoon.
Hi, who's BK by the way?
Hello.
Who's BK?
BK?
I'm going to ask him. There's a name here.
Bharani.
Varani. Okay. Okay. Now Ankush.
Yes, ma'am.
Ankush. What is the prognostic? Are there any classifications to tell you which babies will do well, which babies will
Yes, ma'am. Ma'am, I read about 3 classifications. There's the Watterson classification. Then there was which basically categorizes according to the weight of the baby at the time of delivery. So it divides it into group A, B, and C. And A is.
At time of surgery.
Pardon, ma'am?
Weight at time of delivery or time of surgery?
Ma'am, we will generally operate the patient when the baby is stable. So it will be operated in 1 to 2 days. So
it depends then, right? Okay, tell me.
yes, ma'am.
Weight and
Ma'am, the condition of the patient. Another classification talks about pneumonia and the weight of the baby.
What is condition of the patient?
Ma'am, pneumonia. If pneumonia is present
if you
or
don't know
not.
something, say it. Don't just try to pass it off. Let's be clear. So pneumonia and
Ma'am, pneumonia and if there's any severe congenital anomaly.
yeah. So there are 3 criteria: weight,
Yes, ma'am.
pneumonia, and associated congenital anomaly. And
Yes,
then
ma'am.
Spitz in 1994. What did they do?
Ma'am,
What happened
Spitz,
between 1962 and 1994? What happened?
ma'am, there was a grading over into the cardiac disease. We found out about the cardiac defects that were associated with death, and it was classified according.
Which is the criteria that is removed from Waterston from in Spitz classification? It is pneumonia. Okay.
Pneumonia. Okay.
So why was pneumonia removed? Because there was better pre-op management of the babies. They were diagnosed better. They were diagnosed earlier. So pneumonia became a rare phenomenon from between 62 and 90. So pneumonia was removed and you had weight and cardiac anomalies.
And the cardiac anomalies.
Then what happened to Okamoto in 2009?
Ma'am, it also includes a cardiac disease and weight of the baby.
Yeah, but they did some better statistical regression formula and all. So in this, Okamoto was very clear. If some baby is more than 2 kgs with no cardiac anomaly, the survival is going to be 100%. But if the baby is less than 2 kilos with heart disease, less than 27. Okay. So what are the risks? I mean, if we go by these, what now a baby has come to you, right?
Yes.
So what are the risk factors along with death that you will increase, will cause higher risk in the baby?
Ma'am, if the baby has already developed pneumonia because of aspiration.
Okay. What else?
Because the mother will feed the baby and then it will lead to an aspiration.
What else?
Then, ma'am, the weight of the baby is, and the general condition if the baby is dehydrated, electrolytes, lost electrolytes, we will want to do an ABG.
What other? I'm not asking you pre-op preparation. I'm asking you risk factors.
Risk factors.
What else?
Ma'am, any other of the congenital deformities, the bacterial deformities?
Okay. All right. Size of fistula. Okay. Size of fistula is also.
Size of fistula. Okay.
Okay. So where is Bharani?
Good evening.
Okay. Now this baby has come. Okay.
Yes, ma'am.
So how will you identify the anesthetic considerations in this baby?
Ma'am, anesthesia consideration.
Something to do with what Ankush just said. A baby has come to you with TEF, right?
Yes, ma'am.
Diagnosed as TEF. She has given you the history. Maybe we should have. Okay, we'll do one thing and come back to you, Bangli. Let us finish the examination. Okay.
Okay.
Himlata?
Yes, ma'am. Ma'am, I would like to add one more point. Like we said, prenatally we diagnose the baby based on polyhydramnios and small or absent stomach bubble on ultrasound. Now there is this new amniotic fluid biochemical markers which has come up. They are characterized by high protein gamma glutamyl transpeptidase and normal L-leucine aminopeptidase. They have the I read it in the pediatric. They have 100% detection rate.
Okay,
so this is a this is a new thing which I learned. So coming up to the ma'am, Piyush Gupta, the pediatric books which the pediatricians follow.
So I'll talk to you later.
Yes.
Good.
So coming to the examination, the baby was examined in a well-lit, heated room with full consent from the father. She was lying in a flex position with attached umbilical cord clamp. Coming to the general physical examination, general appearance was she was having a soft cry, sleepy with poor spontaneous activity. Heart rate was 112 beats per minute. Blood pressure was 65 by 44 millimeters of mercury. Saturation was 95 to 96% at room air. Respiratory rate was 48 to 50 breaths per minute. Accelerated temperature was 36.5 degrees Celsius, and capillary refill time was less than 3 seconds.
So
Coming to the
findings in this.
Yes, ma'am.
What is the significant findings in this last slide? Positive finding.
Ma'am, BP is slightly on a lower side.
BP is on a lower side. Now come on, Himlata, what is a normal BP for a neonate?
Ma'am, 50 by 35.
So your child is sleepy with poor spontaneous activity. Second, there is tachypnea.
Yes,
right?
Yes.
What is the normal respirator? Now you haven't done this class.
Ma'am, 60 to 80 is normal in a newborn.
In a respiratory rate?
Yes, ma'am.
Okay. And your BP?
And BP is normally we take it the range of 50 to 35 millimeters of mercury.
Why you say it's low? Okay, chalo, next.
Coming to the anthropometry, weight was 1.6 kgs. Head to toe examination. In head, anterior frontal was at level with a size of 1.5 by 1.5 centimeters. Suture lines were filled, they were not separated. No capal hematoma, caput succedaneum, or forceps marks were present on the head. Coming to the face, no dysmorphic features were present, milia was present. Neck, no short neck, webbing, or any swelling. Skin, there were no red or blue discoloration. Limbs, no limb shortening, polydactyly or oligodactyly or radial aplasia. Genitalia, they were normal female genitalia. Per abdomen, the abdomen soft, non-tender, no organomegaly was felt, no abnormal distension, no anal atresia, and she had passed meconium. Coming to the CNS examination.
Yeah. See, now you've written activity normal. There's something confusing about your.
Ma'am, actually, I read it in the pre-term versus term ka examination. So normally they said ki unka their pre-term are normally. So reflexes in reflexes, sucking and rooting reflexes were present. Rest all were not absent. CVS.
Chest findings. S1.
Ma'am, mild in respiratory examination, mild chest wall retractions were present. There was no grunting and no murmur was heard.
Okay. Next.
Lab investigations.
Okay. Now we'll complete your lab investigations.
Okay. Hemoglobin was 16.8 gram percent. Platelet was 2.43. TLC count was 16,200. Sodium potassium was 132 and more than 5.2. And urea and creat was 61 and 1.2. Serum well was 6.0, AST, ALT, and ALP was 69, 14, and 234 respectively. Here's this chest X-ray of the kid. This upper arrow is showing the recoiling of the orogastric tube in the proximal esophageal pouch, and this is a positive finding we got. Dextrocardia in this kid.
No. Yeah, can't say. This is left, huh?
Yes, ma'am?
Yeah, could be dextrocardia. Could be dextrocardia.
Yes, ma'am. It could be dextrocardia.
But the liver is also on the right side, no? Liver is also
Yes,
on the
ma'am.
right side.
Actually, the surgeons confirmed that they felt the impulse, cardiac impulse in the right side.
Tell me one thing, is
thorax.
this the same baby we operated in the OT?
Yes, ma'am. Yes, ma'am. The same
then
baby.
This is dextrocardia. Then this is dextrocardia.
Yes, ma'am.
Yeah.
Ma'am, that's all. I'm finished with the examination. And
You're finished? Okay. Now we come back to Barney. Barney, history
Yes,
exam
ma'am.
investigations are over.
Yes, ma'am.
Okay. First of all, tell me, is there any investigations that are not done that you would like?
Ma'am, we have to do echo also.
Yes. See, this is singularly lacking in our hospital. Neonatal echo for any surgical neonatal emergency is mandatory, because there's a very high association of congenital cardiac enema. Very high meaning how much, Barney? What is the percentage of cardiac association with the TAF?
Ma'am,
Percentage?
ma'am, 50% of the patients will be having 50%.
I think you are talking about total congenital anomalies.
Yes, ma'am.
So it is less than that, 15 to 25% out of those 50%. Okay, so there is some high incidence, and this is one thing that is missed in our center, and echo is mandatory. And I have to tell you that it has happened not on one occasion, on some occasions, that we have done a baby, operated on a baby, extubated the baby, had a very uneventful perioperative period, and post-op, and sometime later echo was done, they had complex congenital heart diseases. Okay, this has happened in our own institute. Okay, so this is mandatory. It is just luck that the baby went off smoothly. Anything else you would like?
Ma'am, ultrasound abdomen to rule out the renal anomalies.
Okay, but that is not really done in emergency. Anything else?
ABG.
ABG to see what?
Ma'am, if the patient is having a pulmonary compromise, to rule out, hypoxia technically. Yes, ma'am.
Anything else?
Other than that, we have to check RDS also, because there is a chance of hypoglycemia in the
Sugar is
patient.
a little important. Okay. Okay. Now you have all these investigations with you. What are the anesthetic considerations in this baby?
Ma'am, anesthesia considerations. There's a chance of aspiration pneumonitis because of the fistula.
I'm asking you for this baby. Okay, you're right. There is in generic you're speaking that there might be pneumonia, right?
Yes, ma'am.
But when you talk about a neonate coming for congenital heart disease, how will you start? Whether the baby is term or not term, these things are important. Baby is full
depends on
low
the
birth
weight.
weight or normal birth weight, right? So you
Yes,
have, whether it's a term baby, this is a term baby, low birth weight, right? So you're
1.6
why are you
kg.
interested in anesthetic considerations, Barney?
What, ma'am?
Why am I asking you this question? What are the anesthetic considerations?
Ma'am, what are the things we have to put? In low birth weight babies, there is an increased chance of.
I'm not asking you specifically for low birth weight or anything. I'm saying when we write down anesthetic considerations, now it is in your PAC chart regularly, isn't it? So what is the purpose of writing this anesthetic considerations?
And what are the things we have to take care of during that surgeries, pre-op and post-op, intraoperative?
It helps in two things. First, it grades your risk. Okay, so you can grade the baby or the patient in whichever ASA category and take due risk consent. Okay. Second, your plan of anesthesia and what you have to, as you said, look out for. Okay. So this is important for us actually. Pre-op preparation in anesthesia always. When you're prepared, you see this in any case of a difficult airway. When you are prepared, you will never get into trouble. But when you are not prepared is when you get into trouble. So when you fill that column of anesthetic considerations, you're defining a lot of things, your plans, your points of care, everything. It's very important. So now in a neonate with TEF, I have told you two things: weight, term baby, prematurity of the baby. You said pneumonia. Anything else?
Ma'am, you're asking for considerations.
Sorry?
You are asking about consideration, other considerations.
Anesthetic considerations, yes. Only specifically for this TEF baby, for a TEF baby.
Ma'am, there's a chance of stomach distension because of the PPV.
Okay. What else?
And electrolyte imbalances and dehydration, and then level of fistula, whether it is in high fistula or low fistula, matlab proximal or distal fistula.
How does that affect you?
Ma'am, intubation difficulty.
What is
There's a chance. Not high fistula, it's a proximal or distal fistula.
Is important, okay? Position of fistula.
Position of fistula.
For intubation, endotracheal tube positioning, etc.
Yes.
And we omitted to say congenital heart disease or any other congenital association.
Anomalies.
Maybe a anorectal thing, and we cannot put a caudal catheter. Maybe we had a plan of putting caudal catheter, right?
Yes.
Okay.
Yes, ma'am.
Thank you.
Another risk like.
Anything else?
Then other risk like hypoglycemia, hypothermia.
Okay, that is a generic neonatal thing. I'm talking now specifically. Okay. You have a point. Tapesh is there? Tapesh is not there. Tapesh is there? Vidhan? Tapesh is not there. Vidhan is not there. Who is
yes, ma'am, I'm here. I am here, ma'am. Vidhan.
अच्छा विधान आवाज नहीं सुनी मैंने बेटा इसको प्री-op कैसे मैनेज करोगे now baby has come you know कि प्री-op में है इसको how are we going to pre-operatively optimize this patient?
Okay, ma'am. Ma'am, first of all, baby have a dribbling of saliva. So first of all, I will put the esophageal tube and suction of that tube to prevent aspiration. Second thing, I will check RBS to know baby is hypoglycemic or not. Third one I will prepare for मैम पेशेंट हाइपोथर्मिया में चल जाए उसके लिए प्रिपेयर करेंगे उसको
बहुत अच्छा very good I'm happy you are thinking yes
I will further I will explain to her parent his or her parent about intra-op condition and I will take consent high risk consent मतलब कि intra-op hypoxemia हो सकता है ड्यूरिंग रिट्रैक्शन तो ये कंसेंट ले लेंगे पेशेंट के अटेंडेंस से
ये तो हम बताते नहीं पेशेंट को कि रिश्तेदार को
ओके मैम
बट सर्जिकल रिस्क तो हम बताते हैं एनेस्थेटिक रिस्क
यस मैम
ठीक है गुड और कुछ करोगे अरेंज करना चाहोगे
मैम बी प्रिपेयर ओटी इन नॉर्मोथर्मिक तो नॉर्मल टेम्परेचर रखेंगे नॉर्मोथर्मिक टेम्परेचर ऑन ऑल फ्लूइड्स एंड अगर इफ रिक्वायरमेंट ऑफ ब्लड
नहीं बेटा नॉर्मल टेम्परेचर रखोगे कैसे रखोगे क्या टेम्परेचर रखोगे
मैम 27 डिग्री सेल्सियस
27 28 तो ये नॉर्मल टेम्परेचर तो नहीं होता ये तो वार्म होता है ना ओटी का टेम्परेचर कितना होता है विधान ओटी का टेम्परेचर कितना होता है
मैम आई डोंट नो
नॉर्मल ओटी का टेम्परेचर होता है बिटवीन 21 एंड 21 के करीब होता है 21 22 हाँ हम लोग अपनी ओटी में रख रहे हैं नियरली ऑलमोस्ट 24 एक्सेप्ट फॉर ऑर्थो एंड न्यूरो बिकॉज हमारे पेशेंट थोड़े सिक आ रहे हैं emergency में and neonate pediatric OT रखते हैं around 28 so that is a very good thing you have said we will warm the OT बोलते हैं not normothermia
okay ma'am
I know somebody who cleared a post of interview of a consultant because when they started discussing a neonatal case the first thing he said was when I get information about case I will call the nurse and tell her to warm the OT वो interview वहीं खत्म हो गया ठीक है
Yes, ma'am.
So warming of OT and cleaning fluids and IV fluids, है ना?
Yes, ma'am.
बहुत बढ़िया विधान. Okay. अब आपका preparation हो गया आपको patient अंदर ले जाना है, ठीक है?
Yes, ma'am. Yes, ma'am.
तो अच्छा but surgical plan तो बताओ इसका द सर्जन ने आपको बोला है कि हम इसमें करेंगे प्राइमरी रिपेयर।
यस मैम।
अब हम करेंगे इसमें प्राइमरी रिपेयर। आप मॉनिटरिंग क्या करोगे बताओ?
मैम पल्स ऑक्सीमीटर, ईसीजी, टेम्परेचर और मैम बीपी एंड आफ्टर इंटुबेशन इंटाइडल CO2 चेक करेंगे, यूरिन आउटपुट देख लेंगे मैम।
और कुछ?
मैम मैम जनरली
इन्वेजिव लाइन डलती है इनमें?
मैम इन्वेजिव लाइन अगर मैम इको हो रखा है और उसको कार्डियक एनोमैली है देन आई विल पुट आर्टियल लाइन। और मैम एक केस और देखा था जिसमें कि सेंट्रल लाइन डलवाया था हम लोग से, वो अगर उन्होंने टिपियन प्लान कर रखा था तो सेंट्रल लाइन डलवाया था, अदरवाइज जनरली नहीं डलता।
वेरी गुड वेरी गुड वेरी गुड विधान, वेरी गुड। मुझे अच्छा लग रहा है दैट यू आर नॉट स्टिकिंग टू बुक एंड अपना बोल रहा है, वेरी गुड। एक और कंडीशन हमने हाई रिस्क फैक्टर में नहीं बोला एंड दैट वाज एक ओपन, बिकॉज हम लोग देखते ही ओपन रिपेयर है, बट थोरैकोस्कोपिक रिपेयर भी होती है। तो जिस पेशेंट में थोरैकोस्कोपिक रिपेयर होगी उसमें भी आर्टिरियल लाइन डालते हैं बिकॉज हीमोटाइप।
ओके मैम, बट मैंने देखा नहीं, वो टीम देखा
नहीं
नहीं।
होता नहीं है बेटा, इन सब्डिविजन वी आर नॉट डूइंग थोरैकोस्कोपिक रिपेयर। आई
Yes,
एम नॉट
ma'am.
अवेयर इंस्टीट्यूट में हो रहा है कि नहीं हो रहा, हो रहा होगा नोइंग देम, बट हमारे यहाँ नहीं हो रहा। एनी अदर? आपने बिल्कुल ठीक बोला। एक होता है बेटा प्रीकॉर्डियल स्टेप, इसमें हम रखते हैं, ये देखो ये पहले की टीचिंग है, हाँ, जहाँ हम पहले एंड हम रखते थे स्टमक में। स्टमक में क्यों रखते हैं?
प्रीकॉर्डियल स्टेट मैम, प्रीकॉर्डियल स्टेट
स्टेथोस्कोप एक स्टमक में, एक एक्सिलम, मतलब प्रीकॉर्डियल में।
मैम अगर वो जो टैप का जो फिस्टुला है अगर उसके थ्रू लीक हो रहा है और डायरेक्टली एब्डोमेन में जा रहा है तो उसके थ्रू हम सुन सकते हैं कि उसमें गैस इन्फ्लेट हो रहा है कि।
वेरी गुड वेरी गुड विधान, आई एम वेरी हैप्पी विद यू। अच्छा समृद्धि, समृद्धि।
Yes, ma'am.
Beta, have you ever seen a patient who has not who has come for a repair as a secondary sitting? First sitting में gastrostomy and esophagostomy होती है? Have you seen that?
No, ma'am. I've seen only one case of TEF, and that was for primary repair only.
Oh, how come you have seen only one case of TEF? Beta, I don't know. Why should that be? अच्छा, आपने anybody has seen a baby come with secondary stage repair? First stage is gastrostomy, and has anybody seen a TEF जिसमें esophagostomy और gastrostomy होती है? देखा है? किसी ने नहीं देखा? नहीं देखा? हेमलता देखा है?
मैम मेरे पेशेंट में प्राइमरी रिपेयर हुआ था।
उन्होंने नहीं दिया because things have improved a lot. When I was a resident of your age, उस टाइम पे पहले प्राइमरी रिपेयर होता था in that sense कि पहले esophagostomy निकालते थे and gastrostomy निकालते थे, and then they used to wait for the baby to basically आप समझ रहे हो ना, esophagus to drain the upper pouch and gastrostomy to feed. Okay, तो दोनों पाउच को बाहर कर देते थे, understood ना? So this is
Yes,
so that the baby gains weight and then they used to do repair. But even today it is done. In which circumstances is it done? When
the gap is very large.
हो सकता है when the gap is very large, और हो सकता है the baby is sick. And there is also the gap, long gap fistula जो आप बोल रहे हो ना, आप वो बोल रहे हो ना long gap fistula. So how do you know that long gap fistula? How much should it be?
Ma'am, 2 to 3 vertebral bodies.
2 to 3 vertebral bodies. Okay. So what they say is if it's less than 2 vertebral bodies, they can easily do. 2 to 6, then they delay. Then they do esophagostomy and gastrostomy and then repair it later. If it is more than 6 vertebral bodies, that is irreparable. Then they will have to do that major surgeries of pull through and all. Okay. So now we were talking about gastrostomy and esophagostomy. If the किससे बात कर रही थी मैं? Who was answering that question?
Ma'am, Smriti.
Smriti.
Yes,
Smriti,
ma'am.
beta, if there is a gastrostomy, the baby has come with a gastrostomy, then what is the problem we can have as anesthetists? आप समझ रहे हो ना, एक ब्लाइंड पाउच है, वो ऊपर खुल रहा है, esophagostomy है, और एक नीचे वाला ब्लाइंड पाउच is opened as a gastrostomy.
Ma'am, the upper pouch
may
will
not
have.
even be an upper pouch. Upper pouch हो सकता है ना भी हो.
Ma'am, ma'am, if there is an upper pouch, there are chances of collection of secretions in that pouch.
बेटा पढ़ के नहीं आया, पता लग जाता है. Anybody, Nisha? Nisha? Is Nisha there?
Hello.
Nisha?
Good afternoon, ma'am.
Good afternoon, Nisha. If the patient has a gastrostomy, what are we supposed to do? Are we supposed to clamp the gastrostomy? What are the advantages? And if we don't clamp the gastrostomy, what are the advantages or disadvantages?
Ma'am, we
Please understand.
will not gastrostomy, ma'am.
No, first you have to understand this, what I'm asking, Nisha. The fistula hai, it is
Yes.
connected to the lower esophagus. Okay? Got it?
Okay, ma'am. Yes, ma'am.
और उधर
Yes,
से गैस्ट्रोस्टमी में ट्यूब डल गई है. So the fistula is
Okay,
connected to the lower pouch, जो बाहर cutaneous fistula. Got it? Cutaneous pouch. Have you understood it?
Yes, ma'am.
There is a trachea with a fistulous opening into the lower esophagus. So trachea,
Okay.
esophagus are connected. Plus this esophagus which is leading into the stomach has a gastrostomy. Okay? So now when we are going to induce this baby, should we leave the gastrostomy tube open? If yes, why? If not, why?
Ma'am, the distal esophagus has a fistulous opening as well as a gastrostomy one, ma'am. That is
Yes,
what.
very good, very good. Now tell me.
Ma'am, we'll have to clamp it, ma'am.
Okay, if you clamp it, what is the advantage?
Ma'am, if we clamp it, ma'am, when we are giving IPTV, it will prevent
Yes.
the gas
Very
from.
good. It will prevent what? Loss of ventilation, right?
Yes, ma'am. Yes, ma'am.
Yes. So it prevents loss of ventilation. But what happens? Disadvantage. Reflux. Okay?
Yes, ma'am. Yes,
Reflux.
ma'am.
Now,
Yes,
if we
ma'am.
leave it open, what happens?
We leave it open, ma'am. Again, there is distension of the abdomen and loss
No,
of
we have
ventilation.
kept it open. Loss of ventilation. And the
Yes, ma'am.
advantage is it decreases chances of reflux.
Yes, ma'am.
Okay?
Yes, ma'am.
Anybody has any doubt on this? Anybody any doubt? Okay, so now the baby has come to you. You have established monitoring. Is Pallavi there?
Yes, ma'am.
Pallavi?
Yes, ma'am.
Baby has come. You have optimized the baby. You have applied monitors on the baby. Now you have to give GA. Okay, what is your modality of induction?
Ma'am, my goal of anesthesia or induction is I want to have an adequate gas exchange, and at the same time I don't want to give very high pressures, so otherwise there'll be gastric distension. So I would go with GA. I would first pre-oxygenate the baby and give
There
opioids.
is no option but GA, right?
Yes, ma'am. We go with GA. First, I'll pre-oxygenate the baby and give opioids.
Are you talking about awake intubation when you said I will go with GA?
Ma'am, we should prefer awake intubation if we can. And
You should do
after.
awake intubation. Have you ever seen an awake intubation?
Haven't seen, ma'am. We give under inhalational and.
No, beta, tell me now. Now, Pallavi, you have said it. Now you tell me. Don't be scared. We are discussing this.
Yes, ma'am.
Have you ever seen an awake intubation in a neonate?
Haven't seen. It's very difficult
So
because
there is
the
a
child.
reason. There is a reason, right? So you said we should prefer. Why should we prefer? You're obviously trying to say that we are not going to cause gastric distension and loss of ventilation, right?
Yes, ma'am.
But why don't we do an awake intubation?
Because it's very difficult to do it in a baby who's very restless, agitated, and they are.
So what happens? The baby is very small. You just suppress the baby and put the tube. You're much stronger than the baby. What is the problem?
Ma'am, the
height. I tell
height.
you, when मेरे seniors हैं, when they were residents, they were doing awake intubation. There's a reason it is not done anymore. You can do it even today if you want. You can suppress the baby and do it. It is not done because there are chances of intracranial hemorrhage. Okay? So these are not done. So now you have decided to do the case under GA. All right? So now how will you induce?
First I will pre-oxygenate the baby. Then I will do a rapid sequence induction and intubation. I would prefer RSI-TC. I would give IV fentanyl to the baby according to his weight, about 1 to 1.5 mics per kg. Then I would supplement it with inhalational. I would give a gentle IPP. Yes, ma'am.
Why gentle IPPV?
Ma'am, because if I give through the fistula, that air can go into the stomach and distend the abdomen. So we'll
you
try.
have decided to give a relaxant. That's why you're doing IPPV, right?
Yes, ma'am.
Which relaxant are you going to do?
Ma'am, I'll prefer to use choline.
Okay. Is choline given now in neonates? Is it recommended? What are we using in OT?
Ma'am, we prefer Atra or VEC in OTs.
No, not VEC, beta, not VEC. Atracurium or rocuronium, right? Why is choline not preferred?
Choline for
Choline
long.
is pretty much out, beta, as a laxant. Though I would still use it, I don't think it. I think it's irreplaceable in certain circumstances because of all the reasons we know about succinylcholine. Okay, so you have decided to use atracurium / rocuronium, right? Then you will give gentle IPPV.
Yes, ma'am.
And then you will intubate. Now we'll come to intubation thodi der mein. Now tell me, can you intubate without giving a relaxant?
Yes, ma'am. We can. If we do an inhalational induction, we have to but deepen the plane so that we can intubate in a spontaneously breathing patient.
Yeah. So a lot of people don't believe in giving a relaxant before intubating. They do a deep inhalational induction, okay, and intubation. Nowadays, propofol is given. When we were young, propofol was not cleared for neonates. Otherwise, in propofol with some inhalational agent, you can intubate. But we are safely intubating using relaxants in our center, like in most centers now. Okay, and we'll come to the reasons also why. So this is how you will induce with. You said either you will give inhalational or you can give. What is the induction agent? IV induction agent you can use thio or propofol, right? The gentle IPPV and the relaxant we said was rocuronium or atracurium, right? We prefer atracurium in neonates, and nowadays this atracurium has come, okay? And we deepen the plane with sevoflurane, right? So now we are going to intubate. Now, Rishabh, where is Rishabh? No Rishabh. Gautam.
Yes. Yes, ma'am.
Gautam.
Hello.
Who's saying yes?
I'm Rishabh.
Okay. Rishabh, now the most important discussion in tracheoesophageal fistula. How will you intubate or how will you position the tube? Anyone? Hemlata, would you like to answer this question?
Yes, ma'am. Ma'am, we do a gentle laryngoscopy, then we insert the tube, normally which is a 3.5 millimeters of an uncuffed tube.
Don't get into trouble by saying this.
Okay.
Now I have not asked you the size of the tube. Now size of the tube is a different thing. Now you go into that physiology and anatomy of airway. Okay, let's not go there. That you will have a discussion. Don't ever commit the size of the tube. This is a 1.6 kg bacha, na? There's full term. You don't think 3 points full term. Normally they recommend 3. But either way, don't get into this size until somebody asks you. Okay. Now you're putting the endotracheal tube. I have right now currently not asked you the size. Okay. How will you intubate?
Ma'am, we will introduce the endotracheal tube in the right bronchus. We will keep our stethoscope over the left axilla, and we will give one person will keep on gently ventilating the patient, and we will keep on withdrawing, keeping the bevel anteriorly, and we will keep on withdrawing the tube. Ma'am, basically we have to keep the tip of the tube distal to the fistula, but proximal to the carina. So as soon as the
this is your aim. This is your aim, that your tube should be positioned distal to fistula and proximal to carina. And
yes,
then what else can you do?
Then we can.
Can you tell me one thing? Now, have you, and why should you keep the bevel anteriorly? I wanted to ask.
Ma'am, so that we don't, so that we can occlude the fistula by our tube. Otherwise, if the bevel is turned left side, we can even
basically the fistula is between the, understand it. Don't say it just by rote learning. The fistula is between the trachea and the esophagus, right?
Yes.
So it is in the posterior wall of the trachea, right? Mostly. So when you put the bevel at the back, it tends to be longer and higher chances of it covering the fistula. That is the purpose. Okay?
Okay.
Everybody's got it? What other way is? One is that you do a right bronchial intubation, withdraw it until you hear bilateral equal entry, right? What is the other ways? How do you intubate beyond the fistula?
Ma'am, we can do a fiber optic bronchoscopy, and then we can see the size of the fistula, and we can see our position of the ET tube.
Yeah. So now tell me one thing. If this patient has a pre-existing gastrostomy, right? There's another way we can do it, that you go into
retrogradely. Yes, ma'am.
No, not retrogradely, not retrogradely. You advance the endotracheal tube till the bubbling stops. That means you've gone past the fistula, right? If you're before the fistula, it is going to bubble into the gastrostomy. The moment you have gone beyond, it will, the bubbling stops. That is if you have a you have to have an underwater seal over there to know. Another thing is you put a capnography into the gastrostomy. Yeah. But now I want to ask you one thing. Have you seen us do this?
No, ma'am.
Has anyone seen us do this? No. But have you seen us have problem with ventilation? Rarely. Why? Why, Himlata?
Because it is always guided by senior consultants.
No, that's not the reason. We don't intubate. A senior faculty does not intubate. And when my presence, generally it is the resident who intubates. I do a fiber optic after that. I don't intubate. Okay. The reason, see, these are theoretical considerations, and these are mostly in large fistulas. This somebody called Salem came up with in the 70s. This going beyond the fistula and coming out. At that time, they showed a lot of improvement in prognosis. Now, why we are not doing it is because you have to understand two things. That majority of the fistulae are very small. So loss of ventilation is very minimal. Okay.
Yes,
and second, these fistula, well, I don't know how many of you have seen fiber optics in TEF patients that we have done. Most of them are pericardial. Okay, so if you are going to go beyond fistula, you're going to go into one of the lungs. Okay, so main reason is the fistula are very small and generally clinical difference nahi hota isme. Okay, now if it is a pericardial fistula, large pericardial fistula, so how can we isolate the lung?
By using Fogarty.
Yeah, Fogarty. We had even started to do this once, but we couldn't do it. We have a learning curve. Any other way? A Fogarty catheter is put into the fistula, right?
Fistula.
And that way it obstructs, obliterates the fistula, right? Any other way?
And we can do rigid bronchoscopy.
Yes. And there's a very interesting thing called tracheoscopy. You understand that? You put the like the scope only in the trachea, and you kind of dilate it, increase the pressure, and then they can and illuminate it. So the surgeon can see the fistula and ligate it. But they have their own complication. Airway pressures go high because of this. I attended a online webinar only in the Kerala chapter. I think I told Anjusha about this Kerala chapter of anesthetists, and they were talking about neonatal emergencies. Actually, I had attended it because we are doing a lot of neonatal emergencies. So there is an anesthetist, I forget his name. He's from Pondicherry. He is doing a rigid fiber optic bronchoscopy in every TEF before induction, before intubation. And you know what his findings are? There are multiple babies, many babies with more than one fistula. There are many babies with tracheomalacia. So these are conditions that we miss. So now it is almost a protocol in a lot of centers, especially in the West, and even in that center, that they are doing a routine pre-op rigid fiber optic bronchoscopy. Okay. Okay.
Ma'am, so these bronchoscopies, they don't cause laryngospasm or bronchospasm in these cases?
No, you have to do it in depth.
Depth, okay.
Okay. Have you've seen us do it? Has it ever caused a problem?
Yes, ma'am.
It doesn't. It doesn't cause a problem if you keep appropriate depth. So now what will you give for who's left? Meghna has answered. Jasmine. 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 Yes, ma'am. Jasmine, what analgesia will you give? I think she mentioned, Pallavi mentioned giving some fentanyl prior to induction. How else can you look after analgesia? If I want to do a opioid sparing, I don't know if people who are working in NEB know that we are heading towards opioid sparing anesthesia a lot nowadays, because to enable extubation of the baby. So if I want to do opioid sparing analgesia, what are my modalities? Jasmine?
Hello, sorry, yes, ma'am.
Where are you, Jasmine? I'm asking you if I want to give analgesia other than opioid.
Paracetamol, ma'am. There is some issue with my phone, ma'am. I was saying it constantly again and again.
Can you hear me now?
Yes, ma'am.
So, opioid sparing analgesia modalities.
Ma'am, we can give paracetamol. We can give epidural, ma'am.
Yes. Which epidural?
Caudal epidural, ma'am.
Oh, also thoracic now. Eh? Anything else? Anything else? Paravertebral blocks. Okay.
Yes.
Ultrasound guided, landmark guided paravertebral blocks. Okay.
Yes.
Now position. Can you tell me how you position these babies?
Ma'am, during ma'am.
Yeah.
We explained them an left lateral position for right thoracotomy. And there
So
is
it's always a right thoracotomy?
Ma'am, I don't know exactly.
And what condition will it be a left thoracotomy?
Ma'am, in the arches on the
yeah, this patient whose extra chest she has put out here, this baby, we had offered the surgeon whether he wants to do a left thoracotomy, but he had persisted with the right thoracotomy. Okay, then you do a left lateral, then what else? Come on, Jasmine, we have to move on.
Ma'am, we will auscultate the patient for the positioning of tube, ma'am.
Okay,
Fine.
and what else? What else? What do you do with the legs? What do you do with the arms? Anybody
Yes, ma'am.
wants to say?
We will keep them in a flex position, ma'am.
And arm also flexed?
It will be over the head, ma'am.
Over the head, extended. Yeah, Hemlata, would you like to tell us the position?
Yes, ma'am. The patient is in a left lateral position with the ma'am, I'm not sure. Ma'am, the right arm is above the head. The right arm is from we have right picture. The right arm is above the head.
Yeah, extended above the head. And why is this? This is open up the thoracic space. The lower limb is flexed. The lower arm is flexed. Okay. And when you're doing these positions, what precautions will you take?
Ma'am, we have to take care of our IV cannula, and we have to make sure that the ET tube has not been displaced, or it has not gone endobronchial, or it has not gone into the fistula. So we have to check for the position of the ET tube again. Then we can even do a mild suctioning of the ET tube before the starting of the procedure, because it can get blocked.
What else?
We have to cover the baby with cotton, and we have to
Good. What else? You have to cover eyes, okay, maintain temperature,
cover.
and you have to ensure that your ECG electrodes, your SpO2 probe, your IV cannula are within your reach to manipulate. Access. They should be accessible. And then a feeding tube is inserted to drain the upper thing, and then the surgeon also puts a rubber catheter into the upper pouch, okay, which we have to gently manipulate intraoperatively to guide the surgeon about position of the fistula. Okay. Now, how do you know what are the conditions in which it's a likelihood that you may not be able to extubate these children? Can you tell me?
Ma'am, a lot of...
Shabnam, let Shabnam tell me. Shabnam, what are the factors that favor post-operative ventilation in these neonates for tracheoesophageal fistula repairs?
Hello. Hello, good afternoon, ma'am.
Good afternoon.
Ma'am, we can consider for other for elective ventilation.
Why? Why should you do elective ventilation?
Ma'am, for like 24 to 48 hours to prevent like chances.
Please don't give me vague answers. When do you ever electively ventilate any neonate? Which are the factors that favor post-op ventilation? Can you answer? Gautam, have you answered?
Yes. Hello, ma'am.
Gautam, tell me which are the factors that favor the post-op ventilation.
Ma'am, if there is any additional associated cardiac abnormalities, which we know.
Good. Any condition that put the baby at high risk in pre-op condition, that becomes a condition for post-op. Whether the patient is preterm, has a congenital heart disease, has pre-existing pneumonia, is hemodynamically unstable. Anything else?
If the patient was already intubated pre-operatively, which most of the tests are.
Very good. Anything else, Gautam?
If the patient doesn't have any intraoperative event like any blood loss or any acidosis, we can expect it. But
if the patient goes uneventfully, but if they have the finding of tracheomalacia, intraop, or multiple fistula, then maybe there is a chance of post-op ventilation. Another condition where there is a higher chance of post-op ventilation is when you do a thoracoscopic repair, because in that you do retraction of the lung and you alter the physiology, right? Now, now suppose you have extubated the baby, then what else do you take care of? Post-op, what do you look after?
Post-op, first we should make sure that the hypothermia and hypoglycemia, they are not disturbed. The patient should be,
so fluid,
the temperature should be ambient, and the glucose level should be monitored. And next, of course, saturation should be monitored, and if it's possible, we can also see the EtCO2 value also. Oxygen supplementation is a very good.
How are you going to?
Yes, ma'am.
Then what
oxygen supplementation can be done, ma'am, with the help of the intubator.
What else? Analgesia, better. Never forget maintenance.
Yes, ma'am. Yes, ma'am. Analgesia. Yes, ma'am.
NG tube. Okay, in these babies, you have to be very, very particular about the position of the NG tube. Where the surgeon has fixed it, it has to be fixed.
It should be there. Yes, ma'am.
And plus, not too much movement of the neck, because they have done a
if there is any extension, if there is any extension, the sutures which are already ligated can give away.
Yeah, very good, very good. What are the long-term complications of these children, Gautam?
Sorry, I'm not very sure of the long-term complication.
Okay. So these children can later in life have tracheomalacia, reflux, okay, esophageal strictures, and recurrent fistulas, okay, apart from lung complications. Okay. So I think we are done with TEF. Anybody has any question? I think we are done with TEF.
Ma'am, there is one more classification which I read about. There was 1993 में Montreal classification.
Sorry, say that again.
93 में Montreal classification आया है, and they took in account बस दो ही criteria लिया था उन्होंने, mortality of 70% in patients with life-threatening anomalies or ventilatory support, and second में इसमें mortality was about 79%, and the second class is rest all babies. उसमें mortality was 7%. So this is this is one more classification which I read about.
So what they're saying is if there is no problem, then there is otherwise normals, only 7% mortality.
Yes, ma'am. Because they said that birth weight has no, since we have advanced NICUs and we can manage low birth weight babies, low birth weight should not be a.
Okay, maybe that works for Montreal. It doesn't work for us, right?
Yes,
maybe you're right. Okay. So thank you, Hemlata. Well presented. Now we'll go to Ira for CDH. Can we take a 2-minute break? I'll just drink some water and come.
Sure, ma'am.
Yeah, 2 minutes.
Yes.
Should we begin? Hello.
Good evening, ma'am.
Hi, good evening. Sorry,
Good
I took a minute extra. Seems India is doing well in cricket. Yeah. Chalo. Ira?
Okay. Yes, ma'am.
Okay. So what
Yes,
is
ma'am.
our
Good
second?
evening.
Good evening.
I'll be presenting a case on congenital diaphragmatic hernia.
Okay, just 1 second. 1 second. Hemlata, I just want you to give your references for reading to everybody else. Okay, share your references for reading.
Okay, I will.
Yeah. Okay, Ira.
Good evening. Baby of Kamla, 5 days, male child from Nazafgarh, product of non-consanguineous marriage, was admitted through emergency, informant being the mother, with chief complaints of rapid breathing. Rapid breathing is occurring since birth, with associated with retraction of chest wall and grunting, and unequal chest rise. Right side more than left side. There is no history of any bluish discoloration of the peripheries of the extremities or lips or oral mucosa. There is no history of non-passage of stool or urine. There is no history of abnormal hand movements, facial abnormalities or limb movements. And there is no large size of head or weakness in the limb or swollen abdomen or discoloration of the skin. Perinatal history. Mother is 28 years old with no known comorbidities, and delivery of the child occurred at home with no follow-up in the hospital since the conception. Child is a full-term baby with spontaneous vaginal delivery with no complication to the mother or baby. Weight of the baby is 3.5 kg. The baby cried immediately, passed stools and urine, and is accepting oral feeds. No history of cyanosis or bluish discoloration on crying. Nutritional history, exclusive breastfeeding till now. Vaccination history, the baby was immunized with BCG, OPV, hepatitis B, and vitamin K injection was also given. Family history, the child is the first child born to the mother, and there is no history of any such abnormality or any significant family history. Social history, good living conditions and socioeconomic status. Summary, 5 days old male child admitted through emergency with chief complaints of rapid breathing associated with chest retractions and unequal chest rise, left side less than right side, with no history of cyanosis, bluish discoloration on crying.
So this patient child reported to the emergency, right?
Yes, ma'am, with with a home delivery and no previous any medical appointments
Okay, I
of
get
the
your
month.
point. Yeah, I get your point. So this is the first. What did we say? First, how many children? First child.
Yes, ma'am, first child.
Okay, so now this baby comes to the pediatric surgical emergency, right?
Yes,
And,
ma'am.
So how is this baby? What will they do next for ultrasound prenatal? Why is come?
No, ma'am. She had no
antenatal
booking.
ultrasound. Prenatal
Yes, ma'am.
ultrasound.
She had no bookings with the hospital or any.
Okay, so there is no prenatal ultrasound. So the child has basically a positive findings are that there is a tachypnea and a scaphoid abdomen, right?
Yes, ma'am. Scaphoid abdomen, unequal chest rise, chest retraction, and tachypnea.
And on examination?
On examination, the baby was examined in a well-lit heated room with consent from mother. On general physical examination, the baby is active and crying. The pulse rate is 120 beats per minute.
It's okay. So hemodynamically stable, right?
The patient is hemodynamically stable, but with a respiratory rate of 64 breaths per minute. And the SpO2, preductal and postductal SpO2, both are 92%.
So, you're trying to say upper limb and lower limb.
No, yes, ma'am. Yes, ma'am.
So you are saying
And there is no difference.
You don't know there is a duct. Basically. All right, not bad. And what about respiratory? You've told me vitals. You've told me first. You've told me general condition. You've told me vitals. And you told me SpO2. Have you told me heart sounds?
Yes, ma'am. Pulse
They're
rate
normal.
1. Yes, ma'am.
I'm asking
Normal.
heart sounds.
Ma'am, in head-to-toe examination in CVS,
No,
S1,
I'm just
S2.
asking you now. Just I've understood you've taken the entire history and exam. Just tell
Yes,
me,
ma'am.
because we have a lot to discuss in CDH. It's a long topic. Okay.
Okay, ma'am. Ma'am, I'll tell the positive.
Yeah.
Okay, ma'am. Okay, ma'am. First in per abdomen, the abdomen is scaphoid.
Do you examine abdomen before chest and CVS?
No, ma'am.
Chest and
Sorry,
CVS
ma'am.
बताओ मुझे.
Yes, ma'am.
Don't be nervous. We are all learning. I don't no problem. Tell me chest and CVS findings.
CVS, both the heart sounds are present, and the heart sounds are shifted to the right side of the chest.
Okay.
In respiratory system, the chest is barrel shaped, and there is retraction of chest wall and grunting. Unequal chest rise is seen, right side more than left side. Trachea is deviated to right side. On auscultation, dullness on the left side of the chest. On percussion, and breath sounds are heard less on the left side with vowel sounds on auscultation.
Okay. Any other positive finding? Abdomen.
Abdomen is scaphoid shaped.
So basically, you have your diagnosis, right?
Yes, ma'am.
The clinical diagnosis heads towards?
Ma'am, congenital diaphragmatic hernia of the left side. And ma'am, investigations were done on chest. All the blood investigations were done, which were on the normal side. In chest X-ray, on the left side of the chest, bowel loops were seen. On ultrasound chest, there was a loss of continuous diaphragmatic line, and bowel loops was collapsed. Bowel loops were seen on the left side, and an ABG was done, in which pH is 7.35, PCO2 is increased 60, and PO2 is 80.
Okay, so there's hypercarbia, hypoxia, and
yes.
What did you say pehle? Usse pehle?
Ma'am, pH is
7.35. Lactate kitna hai?
Ma'am, lactate are less than 3.
क्या बेटा lactate का value बताओ ना बोल दो 1.5.
1.5. Yes, ma'am.
Since we are making it up as we go. Okay, so now you have diagnosed CDH, and you've told us the investigations and the diagnosis. Okay, now let's discuss this. First of all, I want to know how many of you have. It's very difficult to do a head count on a virtual platform, but how many of you have seen CDH? If anybody has, just voice out that you've seen a CDH. I'm trying to say nobody has done a case of CDH in any BOT. किसी ने भी नहीं देखा? किसने देखा है? Anjusha.
I have seen, ma'am.
Ankush has seen. Ankush has seen. Anjusha has seen. Just. Okay, so Ankush, should I direct, and Anjusha, should I direct questions at you? No. See, actually CDH is a little difficult. Like, very honestly, I'll tell you, TEF may, if you get a TEF, your major discussion is around airway, right? And the rest of neonatal anesthesia. CDH by itself, pathophysiology is, you have to understand the pathophysiology, only then you will be able to understand it. Okay, let's start with the basics. Again, we'll start from the beginning of the line. Everybody just try and answer. Jasmine, I need a response, if you're going to move ahead like this. And Jasmine?
Yes, ma'am.
Jasmine, what is the incidence of congenital diaphragmatic hernia? And what is the gender predilection?
Ma'am, I haven't studied this topic, ma'am.
Great. So you don't read, you don't see these cases, and you're doing very well. Yes, Megha?
Hello, ma'am.
Yeah, Megha, tell me what is the incidence of these cases?
1 in 3,000, ma'am.
Yeah, about 3,000, 4,000, and they reflect almost 10% of all congenital malformations, right?
Yes, ma'am.
Now, can you tell me in recent past, about maybe in the last few decades, the morbidity and mortality has come down. Can you
Yes,
tell me
ma'am.
why?
Yes, ma'am. Our ma'am, NICU like NICU management is better nowadays. So the for a congenital diaphragmatic hernia patient, the immediate intubation is necessary. Hello,
Is that
ma'am.
why it has improved?
Yeah, like immediate intubation and oxygenation is done immediately so that we can prevent the hypoxia to the newborn, ma'am.
Okay, what else?
And the operating opportunities are increasing nowadays. Like centers are increasing.
Okay.
Well, it is an emergency surgery, ma'am. So if it is, this is an emergency surgery. If it done emergently, the outcome will be better, ma'am.
Megha, आपने बिल्कुल you have said it the other way around. Okay. Why the morbidity and mortality has improved. Now, please listen to me properly. Is because we have a better understanding of the pathophysiology of this problem. Okay.
Okay, ma'am.
And second, we have understood that it is not an emergency surgery.
Okay.
We have given now, we give time to these babies. We optimize them. We optimize them. What you said about PICU, NICU being better equipped and better informed to deal with these babies is true. Okay. So these children are now preoperatively optimized. They are done. There is no fixed time. There is a criteria of you should achieve certain targets when they are operable, and they are there's a small window you get, but that is when you operate. You prefer to do it in morning hours when there is experienced faculty and a good coordination between the intensivist, the anesthetist, and the surgeon. Okay. So main reason is we have understood the pathophysiology as well as we have understood it is not to be done the moment baby comes. Okay. These are now. So what we call, we have become better practiced at optimization. All right. So again, like TEF, they have a familial association, they have a chromosomal association, and a lot of them, 40% have congenital anomalies, out of which 14% have cardiac anomalies. Can you tell, Rishabh, can you tell me the pathogenesis of, now understand what I'm asking, not the pathophysiology, the pathogenesis of CDH?
Yes, ma'am.
Bolo Rishabh, जोर से bolo, please. We have a lot to cover. नहीं पता तो बोलो नहीं पता.
मैम नहीं पता.
नहीं पता. निशा. आप लोग please try and work in the neonatal OTR if you don't know. Nisha, can you tell me the pathogenesis of CDH?
Yes, ma'am. No, ma'am. There is during the development, ma'am, there is a deficiency in the development of the so that there is
I
a.
can't hear you, Nisha. Can you speak clearly, please, loudly? Beta, I can't hear you. Speak.
Hello.
Bolo. Yes.
Hello, ma'am. During the development, there is a deficiency in the development of the diaphragm, ma'am. So, means there can be two types, either right posterolateral and.
Tell me one thing. From where are you reading? You and Megha are giving very old, very old information. Where have you read this from?
Ma'am, I have read it from Yao, ma'am.
That is why you are all answering like that. Pallavi, can you tell me what is the pathogenesis?
Yes, ma'am. Ma'am, in CDH, there is pulmonary hypoplasia.
Precisely.
And also there.
These children understand. Megha and Nisha, this is not a result of diaphragmatic underdevelopment. This is hypoplasia of lungs. Yes, Pallavi, go on.
Ma'am, there is pulmonary hypoplasia, and also because of hypoplasia, there is a deficiency of surfactant. And also,
I'm not asking you the pathophysiology. I'm asking you the pathogenesis. What you said is correct. That there is a hypoplastic lung. In addition, there is a diaphragmatic development delay, which pushes all that bowel and gut and whatever, and further impairs the development. So what is this thing called, Pallavi? Dual hit theory, right? Have you heard of this word, dual hit?
Ma'am, not dual hit, but
dual hit theory is this, First, earlier it was thought that the diaphragm doesn't develop and that thereby the hernia occurs. But now it is what you said, that the lung is hypoplastic primarily, okay? And then the second hit that comes is that the diaphragm doesn't develop. So all this leads to the this congenital diaphragmatic hernia. Because how did they find that out? Because if it was primarily a diaphragmatic problem, then the hernia should only be where there is a diaphragmatic, the lung should be hypoplastic only where there is a diaphragmatic hernia. But they used to find that the hypoplastic lung used to be bilateral, without a hernia bilateral. Understood? So the dual hit is hypoplastic lung and diaphragmatic problem. Okay, this is the dual hit. This is called dual hit theory. Okay, now what are the two types of defects?
The defect could be either posterolateral or it could be anterior.
Yeah.
The posterolateral is most common, which is called there's a defect that's called Bochdalick's defect, and it could be anterolateral or it could be paraesophageal or it could be diaphragmatic eventurations, in which there is thinning, either diffuse or at some specific points thinning of diaphragm, which leads to abdominal contents pushing the diaphragm to upper, and hence leads to increased tension or increased tension in the thoracic cavity and mediastinal shifting of contents, which occurs on the ipsilateral side. So shifting towards the opposite side.
Okay, this is the other one. Okay, then other one is
diaphragmatic eventurations. Based on etiology, it could be
Bochdalick and Morgagni, right?
Yes, ma'am. Defects of Morgagni.
How many are left-sided, right-sided, bilateral?
Ma'am, amongst the 85% are usually left-sided, less than 5% are bilateral, and 90% are posterolateral.
Okay.
And about
Ankush,
1-2% are anterior.
That's fine. Ankush, tell me the pathophysiology of CDH.
Yes, ma'am. Ma'am, hello?
1, 2, 3 points. Come on.
Yes, ma'am. Ma'am, the pathophysiology of CDH is primarily it's due to the hypoplasia of the lungs. Additionally, there is a right to left shunting.
No. First, you tell me about.
Hello?
Tell me what happens. Then you tell me the consequences right to left side. Tell me what happens.
Ma'am, because of the pulmonary hypoplasia and the additional defect in the diaphragm, the abdominal contents move into the thoracic
Then
cavity.
What happens at a more minute level?
Ma'am, there's vascular changes which are.
What is the vascular change? People have not read and come. What is the vascular change? Gautam, do you know?
Yeah, hello, ma'am.
Yeah, Gautam, what is the pathophysiology?
Ma'am, basically there's a pulmonary hypoplasia, which is in turn causing hypoxia-induced vasoconstriction, which on the long term causes.
What are the structure? Okay, you tell me. We'll come to this consequence, but first, what are the structural problems that lead to this?
Main thing is hypoplasia is the one which is structural. I don't know.
Hypoplasia of lung is one. Then what happens?
Yes. And since there is an additional diaphragmatic defect, there is less room for the lung to grow.
Done. What else?
I don't know that now.
Okay, anybody?
Ma'am, there is muscularization of. Ma'am, there is muscularization.
Okay, bolo Pallavi. Vascularization.
Muscularization of the intrapulmonary arteries and thickening of the media.
So what does
which
this
leads
imply?
to pulmonary, which leads to pulmonary hypertension, increased pulmonary vascular resistance.
So your cross-sectional area of the vessels becomes less.
Yes. So there's more prone to. Yes, ma'am.
So you are prone to vascular hypertension, right? So
yes, ma'am.
आपका lung का hypoplasia है. Then muscularization of vessels is there. Third, there is defective surfactants.
Deficiency of the yes, ma'am. Deficiency of surfactants and antioxidants, which makes them further prone to hyperoxia and induced injury.
Yes. Then what else happens?
There's because of increased right-sided pressures because of hypoxia.
No, then what else? I'm talking about structure. Then I'm trying to talk about what leads to this clinical picture. Okay, this is what I'm trying to talk. That's why I'm saying CDH is a little complicated. So one, you have lung hypoplasia. Second, you have pulmonary hypertension as a consequence of muscularization of vessels. Third, you have less surfactant. So the alveoli are less compliant. Fourth, you have very abnormal reaction to vasoactive substances. Okay, so that is because of some potent vasoconstrictor called endothelin. Okay, so this endothelin, if you see babies with poor outcome, those who have had a very high morbidity and mortality, you find the levels are high. Okay, so they have abnormal response to vasoactive substances. Now, Gautam, you tell me as a consequence of all this, what you were trying to tell me. So there is pulmonary hypoplasia and pulmonary hypertension. Okay, plus deficiency in pulmonary surfactant. So what is going to happen, Gautam?
It causes hypoxia and intense hypoxia induced vasoconstriction. Will are happening.
See, I think I'm going to take this up and explain it to you. Now, what happens when there is pulmonary hypertension plus pulmonary hypoplasia plus some amount of atelectasis, right? Because of surfactant, right? So these are the three conditions you have. So what is going to happen? BQ mismatch. Simple, isn't it? Isn't it? Okay. So this is going to lead to hypoxia and hypercarbia. Got it? If anybody has any problem, please stop me at that time. Plus acidosis. Okay. There is going to be acidosis, hypoxia, hypercarbia. What does this lead to? Increase in what?
Pulmonary vascular
vascular resistance. That will further lead to hypoxia and hypercarbia and acidosis. So it is a cycle. Have you understood? If somebody has not understood, they have to, I'll repeat it. Pulmonary hypertension, pulmonary hypoplasia, and atelectasis. These lead to VQ mismatch. This leads to hypoxia, hypercarbia, acidosis. This leads to increase in pulmonary vascular resistance. This further aggravates the situation. Understood? If there's somebody who hasn't understood, please raise your voice. So I presume everybody has understood it. Now, when there is a rise in pulmonary vascular resistance, what does it do? It leads to right ventricular strain or right to left shunt, increase in right to left shunt, particularly if there is a persistent PDA. Got it? Has everybody got it? Yeah, please. I have to have some response. I can't talk to
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
Yes, ma'am.
Yes. Now, so what do we have to do? Now, right to left shunt से क्या होता है? हमें क्या problem है? If there is a right to left shunt, it leads to hypoxia, है ना? The desaturated blood is mixing with the saturated blood and causing systemic hypoxia, isn't it? So we want to decrease this shunt. We want to decrease the left or the right ventricular strain, right? So if we want to decrease that, what do we have to prevent? We have to treat the pulmonary hypertension. We have to prevent hypoxia and hypercarbia. Okay, because when we reach a situation of right ventricular failure, thereby left ventricular failure, we are reaching a situation of metabolic as well as respiratory acidosis. So we have to prevent this condition. Are we all clear?
Yes, ma'am.
Yes. If somebody has not understood, I'm giving you 20 seconds. Please say you have not understood. I'll keep quiet for 20 seconds. Okay, it seems everyone has understood, because if you understand this, you have understood anesthesia for a CDH. Okay, basically this goes for all cases in anesthesia that you have to prevent hypoxia, hypercarbia and acidosis, but these babies are particularly prone to it. Okay, so now you have a situation where you have to, now you have to understand one thing. Pulmonary hypertension also has two components. One is a non-reversible component these babies have, which is due to hypoplasia and these muscularized or dysplastic vessels. Okay, and there is a reversible component that is the only one which you can handle, and that is vasoconstriction. So we have to prevent vasoconstriction. And how do we prevent vasoconstriction? By preventing hypoxia, hypercarbia, and acidosis. Okay, so we have understood our goals of anesthesia over here. Have we understood?
No.
Yeah?
Yes, ma'am.
Okay. So now we have understood the pathophysiology. Actually, this is the most important thing in CTH. Thereafter, तो सब कुछ easy हो जाता है. Now let's go back to the rest. How do we diagnose? Antenatally, Vidhan? Antenatal diagnosis, antenatal diagnosis बताओ, इसका कैसे होता है? Prenatal diagnosis.
Ma'am, by antenatal USG, we diagnose.
क्या findings होती है? ये कौन से वाले वीक वाले अल्ट्रासाउंड में पता लगती हैं?
मैम 20-24 वीक.
हाँ, तो क्या क्या फाइंडिंग्स हो सकती हैं CDH में?
मैम बॉवेल लूप मैम.
ठीक है, बॉवेल लूप हो सकता है, और क्या हो सकता है?
मैम
पॉलीहाइड्रोमनियोस होता है, ठीक है, herniation ऑफ कंटेंट्स होता है, mediastinal शिफ्ट होता है, ठीक है.
ओके मैम.
नाउ इसमें आपको मालूम है व्हाट इन ultrasound, antenatal ultrasound, what are the prognostic indicators? Do you know?
No, ma'am.
Okay, ultrasound, antenatal ultrasound में prognostic indicators होते हैं. If जितनी जल्दी diagnose हुआ उतना बड़ा problem, because if it is diagnosed early, it means there is a large defect. Okay.
Yes, ma'am.
Second होता है liver herniation. If liver is herniated, it is a poor prognosis.
Yes, ma'am.
And if liver is not herniated, on the other hand, the mortality is low. Okay. All right.
Yes,
ठीक है.
ma'am.
तो ये होता है antenatal diagnosis. Postnatal कैसे diagnose हुआ? Postnatal क्या clinical features होते हैं विधान?
Ma'am, patient present with dyspnea and respiratory distress, and maybe due to respiratory distress, maybe have central cyanosis.
अच्छा, okay. कभी देखा है cyanosis CDH? अच्छा, और?
Ma'am.
अब सिस्टम वाइज जाओ ना. आपने रेस्पिरेटरी डिस्ट्रेस, हाइपोक्सिया बोला, ब्रेथ साउंड्स कम होंगे.
Yes, ma'am.
हार्ट का क्या होगा? डिस्प्लेस्ड हार्ट साउंड्स.
Yeah, ma'am.
है ना. स्कैफोइड एब्डोमेन होगा. ठीक है.
Yes, ma'am.
कंफर्म कैसे करते हैं?
मैम कंफर्मेशन बाय चेस्ट एक्सरे से कर लेंगे मैम. बॉवेल लूप इन चेस्ट मिलेगा तो
चेस्ट एक्सरे से करते हैं. और अगर आपका एंटीनेटली डायग्नोज हो गया, एंटीनेटली अल्ट्रासाउंड पे डायग्नोज हो गया, चलो विधान आयरा से पूछते हैं. आयरा, एंटीनेटल डायग्नोसिस कंफर्म दैट द चाइल्ड हैज anything that can be done antenatally?
Yes, ma'am. Ma'am, antenatally we can go for fetal surgery, which is feto-endoluminal tracheal occlusion. What happens is because of that, the fluid doesn't, it gives a chance for the alveoli to open up and for the growth of the...
Explain it properly. ये intrauterine जो fetal surgery है, the head and neck is removed and trachea is occluded. As a consequence of that, आप जो बोल रहे हो, हाँ बोलो. Lung secretes fluids that is accumulated, which stimulates growth factor.
Yes, ma'am. So, ma'am, because of that, it will give a chance to the lung to grow, and so that the hypoplasia can stop. But ma'am, this surgery doesn't have much. It's done in one place only, in a feto trial in Europe. That's where it is done, but it doesn't have much evidence about it.
These trials is that they have babies few and far and different centers following different protocols. That is why abhi tak to it is, I think this feto trial has been going on for a good 15 years, I think, hai na? I don't know, but so far it is showing a very plus minus, and they're saying it is better in children with a poor prognosis, hai na? And what about use of surfactant and corticosteroids antenatally? Is there any role?
Excuse me, ma'am.
Yes.
Ma'am, please explain the feto-surgery again. It's not clear. What exactly?
Fetal surgery is better. Fetal surgery, you understand that you do a kind of a hysterectomy and the fetus is removed. Like you have to understand fetal surgeries can be endoscopic or they do exteriorizing. Okay. So in this case, it is probably exteriorized, and not that I've seen a fetal surgery myself. So I'm just telling you what I've read. And the head and neck is exteriorized, and then the trachea of the neonate is blocked. Okay. Now what happens is naturally the lung produces fluid. Okay. So this fluid keeps accumulating in the lung, fetal lung, and distends it. This stimulates a growth factor. Okay. Because our primary pathology is fetal hypoplasia, lung hypoplasia, right? So
Yes,
it is meant to overcome that. That is the principle behind fetal surgery, but it is not showing outcomes are plus minus. Whatever literature you'll read, it's plus minus. They say it is working better in higher risk babies, like those babies who have liver herniation. Okay.
Okay.
All right. Understood?
Yes, ma'am.
Okay. Ira, tell me Hemlata, tell me the CDH classification.
CDH classification.
आता है तो बोलो, नहीं तो we'll move to the next.
हमें याद नहीं है.
Okay. Anjusha?
ये आगे पिछला.
Samriti? Nobody has read and come ना. TEF तो फिर भी कोई पढ़ के आया. CDH difficult topic कोई पढ़ के नहीं आया. Anjusha, classification.
Hello.
Yeah, Anjusha, classification.
Mainly it is divided into morcacne and posterolaterally.
No, I'm not asking you the names. I'm asking you classification of CDH, size of CDH.
That I don't, and I'm not sure.
I'm not asking you for nomenclature. I'm asking you for side. Gokila, have you read? Gokila is here. Is Gokila here? Tapesh, Gokila is here.
Hello.
Gokila, what is the classification of CDH?
Ma'am, based on etiology.
No, beta. There's a size now. Anybody knows? Anybody?
Ma'am.
Ma'am, I'll Rohan here.
Ira, you tell us. Ira will
Ma'am,
only answer all the
under
questions.
class.
Bolo.
Ma'am, if there are small defects entirely surrounded by muscle, then it is type A. If less than 50% of the chest wall is chest wall with absent diaphragmatic tissue is present, then it is type B. If it is more than 50% chest wall with absent diaphragmatic tissue, then it is type C, and D means complete absence of a hemidiaphragm.
Okay, and what about scoring system? Do you know any scoring system? CDH scoring system?
Ma'am, CDH scoring? No, ma'am.
There are five or six factors you take into account. If the birth rate is less than 1.5, APGAR at 5 minutes is less than 7. If chromosomal abnormalities are present, major cardiac anomalies are present, and pulmonary hypertension on echo. Based on the presence of these factors, they are divided into low, moderate, and high mortality. Okay. Now, bilateral CDH is also poor. Okay, poor prognosis. Poor prognosis. So in the end, Ira, how will we?
Yes.
What are the prognostic indicators of a baby of CDH?
Ma'am, severity and ma'am, we have
Antenatally, you had already
antenatally. Yes, ma'am.
So postnatally,
yes, ma'am. Ma'am, in antenatal, we'll see in antenatal if the score of lung to head ratio is more than 1.4, then it is severe. If there is, if we do color flow Doppler and through the liver, and if the liver is herniated, then it is severe. And we'll do, and through fast spin echo MRI, we can come to know if the lung volume calculated lung volume assessment, then we'll come to know about the severity. And in postnatal, we have to see that if the defect is the size of the defect is large? Are there cardiac and chromosomal abnormalities? Is there severe pulmonary hypertension? If the Apgar score is low at 5 minutes, birth weight is low, and contralateral lung is small, if there is bilateral CDH, and even in right CDH, the complications are more. So through that, we can come to know about the severity.
I have a feeling, Ira, this is going to be a communication between you and me. Nobody else has read anything. Can anybody tell me, like we have in the beginning of the talk, we have class or discussion on CDH, we had said it is not considered an emergency anymore. We have to pre-operatively, she has told you what are the risk factors. We have to optimize these risk factors. So what is the post-op, postnatal management of this? What is the recommended postnatal management of these children? Can anybody tell me? Now baby is born, they have a congenital diaphragmatic hernia or antenatally diagnosed. However, who wants to answer? I'm not going to ask, nobody is read. So somebody might as well volunteer.
Pallavi.
Yeah, Pallavi, bolo.
Ma'am, post-surgery concern, these children are likely to have abdominal compartment syndrome.
Beta, I'm not talking
because
post-surgery. We have not reached post-surgery. I'm asking, baby has been delivered and has to be kept for, obviously the surgery is the only treatment of CDH. But prior to surgery, how do we manage these babies? How do we optimize these babies?
the goals of our management should be that we need to reduce the pulmonary vascular resistance in shunt. If there is any acidosis present, we should try to correct the acidosis. And we should correct the hypocarbia, improve oxygenation.
How do you do all this?
Ma'am,
very nice answer you've given, but how do you achieve this?
Ma'am, we can send an APG and look for acidosis. If that is present, then we can correct it. We look for
How do you correct it? How do you do all this? How do you correct hypoxia? How do you correct hypocarbia, hypercarbia? How do you correct acidosis? It's all a... See, first of all, in these children, if there's antenatally diagnosed, then you deliver the baby as close to term as possible so that you have a good birth weight baby. Okay. Outcome in cesarean and normal vaginal delivery is the same, so that you don't have to worry कि इसका cesarean करके निकालो. Then you have to put a nasogastric tube, okay, to drain.
Yes, ma'am.
And then bag mask
Yes,
ventilation is kind of avoided to prevent gastric distension and barotrauma. All right. So now these children mostly need intubation and ventilation. Very rarely are they so stable. They do come. We get babies quite often who come like this and are intubated, operated, extubated on table and go. But mostly they have to be intubated and ventilated. So they have lung protective ventilation strategy. Okay. So
that's that is, yes, ma'am, that's gentle ventilation with permissive hypercapnia and limited
so
pressures.
that is what I'm asking. What is that? What does it consist of? What are your targets?
Ma'am, we're going to give small tidal volume with limited. We try to keep low airway pressures around 25 to 30 centimeters.
Yes.
We'll try to maintain a saturation. We'll try to maintain a saturation around 90 to 95%.
It's more
we
than
will let it.
It's more than 80.
More than 85. Okay, ma'am, more than 85%. Then we can let the PaCO2 to rise a bit higher than normal. That is around 60 to 65. That is
Very
permissive
good.
hypercapnia.
Very good. Very good.
And we can allow the patient to breathe spontaneously.
Spontaneously, it's difficult. You will have to ventilate in this. Yeah, then you don't need to intubate if you have to be spontaneous, right? And you can keep a PEEP of 3 to 5 centimeters.
Yes, ma'am.
And then do your X-ray chest, repeat your EPGs and echo. Now, severity of pulmonary hypoplasia, this is an APG. You can also see this QS-QT ratio or alveolar arterial difference, okay, on APG. If on a FiO2 of 1, it is less than 400, then the child has a chance of survival. If it's more than 500, then it's a non-survival baby. Okay. Now you all have to read. It's a little difficult for me to keep my enthusiasm when I'm not getting any response. Now between Ira and Pallavi, anybody else is read, they can please raise their voice. Otherwise, we stick to Ira and Pallavi to have a discussion. Anybody else has read? I'm open to all. Who has read? Please, who has read? Only Ira and Pallavi have read. That's just wonderful. Manya has also joined us. So, Ira?
Yes, ma'am.
So one is mechanical ventilation. Now, how do you antenatally? Now, this is just to complete our theoretical part of our lecture, because my motivation is completely zero because nobody has read. It's quite pathetic, actually. How do you manage pulmonary hypertension in a neonate pre-operatively?
Yes, ma'am.
Optimization, we are discussing optimization of the baby prior to surgery. Okay.
Yes, ma'am. It is the surgery. This is not. Yes, ma'am. Ma'am, we have to medically optimize the patient before timing for the surgery. And for that, we can go for firstly pharmacological methods, intubation and mechanical ventilation, high frequency oscillatory ventilation, and ECMO.
Okay.
In intubation and mechanical ventilation, discuss all the protective ventilation methods. Initially, firstly, they used to do aggressive ventilation.
What next?
Now, in pharmacological methods, we'll go for pulmonary vasodilators like nitrous oxide. So it has shown to it has nitric oxide. Sorry, ma'am. Nitrous oxide has to be avoided. Nitric oxide should be given as a pulmonary vasodilator. It will help in dilating the. Hello, ma'am.
How does a pulmonary vasodilator help?
Ma'am, pulmonary vasodilator by inhalational, it does not have effect on the systemic vessels, but on the pulmonary vessels. It has shown not a much of a difference, but it has shown in few cases that it does provide some help in vasodilation.
It increases the VQ mismatch, and also decreases right to left shunt because it causes pulmonary vasodilatation. Okay, yeah, it's not shown to be a very good, not shown to have very good outcomes. And what about high frequency oscillatory ventilation?
Yes, ma'am. Ma'am, and we can use sildenafil, prostaglandin, PG.
Asking you about HFOV.
HF. Yes, ma'am. Ma'am, when the conventional things are not working, ventilation and all is not working, we'll go for high frequency oscillatory ventilation. In that, ma'am, it decrease. Ma'am, how it is done?
It decreases pulmonary artery pressures. It increases oxygenation, decreases right to left shunt. But again,
it decreases.
Survival is not. Tell me about ECMO.
Ma'am, ECMO also decreases the right to left shunt, decreases pulmonary vasoconstriction, which helps the growth and functioning of the lung tissue. It is done before the surgery when the conventional methods are failing. We choose the patients. It has a risk and benefit ratio. So in more severe or patients with more mortality, they are usually chosen. The conditions are that the PIP is more than 85. The oxygen saturation is not.
You're reading wrong, na? PIP is more than 28. PIP 85 तो बहुत barotrauma हो जाएगा.
No, ma'am. PIP more than. Pardon, ma'am. PIP more than 28. And yes, ma'am.
Okay.
Ma'am, peak inspiratory pressure more than 28, and if the oxygen saturation is not maintaining above 85, and PaCO2 is high, more than 67, and preductal and postductal saturation, the preductal saturation is less than 80 and postductal is less than 70. The pH is less than 7.15 and the lactates are more than equal to 5. Then we will choose the patient to undergo ECMO. Or if there is refractory hypotension, then also we'll choose and urine output is less than 0.5 ml per kg per hour for 12 to 24 hours. In that cases, we can choose ECMO as an option, but there are complications. There is only 50% survival and long-term problems within first year of life, like significant mortality, long-term physical and neurological development morbidities, and risk like bleeding, intracerebral hemorrhage, and sepsis. So it is not very much preferred. We have to choose the patient population accordingly.
What is the contraindication for ECMO?
Contraindication.
Gestational age preterm, less than 34, weight less
Yes,
than
ma'am. Gestational age less than 34 weeks, weight less than 2 kgs, any pre-existing intracranial hemorrhage or congenital heart disease or neurological abnormality or congenital
What other
anomalies.
now pharmacological drugs are there to treat pulmonary hypertension?
Ma'am, sildenafil, prostacyclin have been seen to be used, and ma'am, prostaglandin E1 is used, but in very severe cases because it will increase the PVR, but it offloads the right ventricle, and
So this is what I
that is
want
important.
to know. It should be like some people will give this. They want to maintain the patency of the PDA because it decreases the right strain, right? Right heart
Yes,
strain.
ma'am. Yes,
But then
ma'am.
it increases hypoxia and
The
heart strain.
hypo.
So you have to keep a balance.
Balance in severe cases we can use it because if the RV fails, the cardiac output will decrease, so we have to choose accordingly, and we can use inotropes and vasopressor drugs for the organ perfusion. So it will help by decreasing the right to left shunt, and it will decrease the systemic vascular resistance and impaired cardiac function, so that will also be helpful to treat pulmonary hypertension.
And we can use neuromuscular blocking drugs to take care of the asynchrony of the ventilation, right?
Neuromuscular blocking. Okay, ma'am.
So, what is the surgery we do? We basically we have to. What is the optimum timing of surgery according to recommendations? In the beginning of the talk, we just said that this is an elective surgery. You have to optimize the patient. There is a narrow window, enough. So, what is that optimization criteria, Ira?
Ma'am, we have to the triad includes cyanosis, dyspnea, and dextrocardia. So we have to look that the map should be normal. The preductal SpO2 should be 85% and above on an FiO2 of less than 50%. The lactate should be less than 3 millimole per liter, and the urine output should be more than 1 ml per kg per hour.
So this is your optimization. So now surgery is returned. What surgical procedure is the only therapeutic option for CDH? In that you are supposed to return the gut contents and close the defect, whether you do it with a primary repair or you put a patch. Now,
Yes,
Pallavi, you tell me advantages of open versus thoracoscopic repair of CDH.
Ma'am, thoracoscopic repair is that leads to, ma'am, in both there is CO2 retention.
In both.
But ma'am, the degree of
I'll ask you another way. What are the advantages of thoracoscopic repair
ma'am, in yes, ma'am, in thoracoscopic there is better visualization, so the surgeon will be able to ligate they will be able to do it under vision, and hence the procedure will take less time, and early stabilization of the patient can happen.
It actually takes longer, but your outcomes take less time. To recover takes less time. And what else is the advantage?
I don't remember.
Earlier recovery, less pain, less scarring.
Yes, ma'am. Yes, ma'am. In thoracotomy, patients will have a lot of pain,
What
and
are
also
the
chest.
disadvantages? What are the disadvantages of thoracoscopic surgery?
Ma'am, patient might require post-op mechanical ventilation.
Yes, and because they will have your retractions, so your managing your gases is more difficult, your oxygenation and carbon dioxide, so it can worsen your pulmonary hypertension in that sense. So you have a little harder time managing the VQs and the hemodynamics of these patients. Okay, in which cases are open done and not thoracoscopic?
Ma'am, in stable patients, we would prefer to do open.
In thoracoscopic
severe
large defects, sick patients, and जिसमें आप like abdominal syndrome कह रहे थे ना, which you can't close. In these babies, you do mandatorily open. Okay, all right. So now tell me, what are the anesthetic concerns of a baby of CDH for surgery and anesthesia?
Ma'am, the fun is because it's a pediatric age group, so all the problems of pediatrics.
Neonate, not neonate. Not pediatric, neonate.
neonates, general problems of neonates, and also there might be associated congenital anomalies with them. And then specific to CDH, it could there could be pulmonary hypoplasia and reduced reserves, oxygen reserves. It could lead to pulmonary hypertension, persistent pulmonary hypertension for the baby. There could be persistent fetal circulation, right to left shunts present. There could be hypoxia, hypocarbia, mixed acidosis, metabolic and respiratory acidosis present. There could be heart failures, and there could be systemic hypotension, electrolyte disbalances leading to dehydration of the child, or the child could eventually land up in shock. And because
Leading
of
to
small
dehydration. Okay.
because
So
of
how
small
will you
lung
preoperatively assess this baby?
in pre-op first we will we will pre-medicate, we'll secure an IV line for the baby.
I'm talking about pre-op entire assessment. Now you've taken a history. Okay, what else will you prepare before you start the anesthesia? You've taken a history. This is typical. What else do you do in a neonate? Fluid management, sugar management.
Yes, ma'am. And the OT should be pre-warmed. Then IV lines should be taken for the baby.
Good,
Then
very good.
while transferring the baby from the pre-op to the OT room, he should be well covered. His head, everything should be covered. Inside the OT, then we can also take arterial line, and especially here we can take 2 arterial lines if we need, one in the upper limb and one in the lower limb for monitoring preductal and postductal. Then we can also we can keep the inotropes and the emergency drugs ready. Then we can we put in a nasogastric tube and decompress the child.
And another thing, I think in all neonates you should kind of remember is always to have airway equipment of appropriate size ready. You should have you should have already thought about the size of the endotracheal tube, what depth you're going to put it on, put it in. So all these things should be thought through. Okay. Now, Ira, now this baby is optimized, brought to OT. What is the monitoring you're going to do?
Ma'am, we have to be careful with, one is we have to avoid all the things which will lead to increased PVR like hypothermia, hypoglycemia.
I'm talking about only monitoring. I'm talking about monitoring. We haven't come to GA.
Ma'am, like we have to continuously monitor the ECG. We have to use 2 pulse oximeters, one for the preductal SpO2, that is on the right hand, and on the foot for postductal saturation, ECG. And ma'am, capnography. Yes. Then since we took arterial line, acidosis is seen in the patients, so we have to put an arterial line and we have to do arterial so that we can take EBGs, and also we have to do BP monitoring because hemodynamic instability is seen in such patients, and we have to monitor the temperature. The patient should not go into hypothermia because it will lead to increased PVR. And we'll do urine output monitoring to have so that we know about the fluid, so that we can assess the fluid management, and we'll monitor the CVP for the same. And because we'll have to give the inotropes, so CVP also has to be monitored.
What are your goals of anesthesia in this case? We've discussed pathophysiology, right? So what is your goal?
Yes, ma'am.
From there you get your goal of your anesthetic concerns and your pathophysiology. What are your goals of anesthesia?
Ma'am, that the patient should not go, that a PSU
when your target, when you're planning your anesthesia, what is it that you're going to take care of particularly in these babies? I think I repeated it many times, Ira. Prevent hypoxia, hypercarbia,
yes, ma'am,
and maintain hemodynamic stability. Okay.
Goals
so
are to.
How will you go about it? Now your monitoring is in place. You have all the drugs.
Yes, ma'am.
You optimize the patient. You have an ABG. So what are you going to do next?
Ma'am, now we'll pre-oxygenate the patient. We'll do adequate pre-oxygenation. And before that, we'll do nasogastric tube decompression. Then we'll pre-oxygenate the patient. and we have to intubate the patient. Ma'am, in these cases where I read, it was that awake intubation is preferred.
Not anymore. Not anymore. I don't know. They can say spontaneous intubation, spontaneous ventilations. Awake intubations are not done unless it's a part of resuscitation. You know, I don't know where you've read it. We can go through this again. You can come. We'll discuss where you've read it. Huh?
Okay, ma'am.
Yeah. So.
And ma'am, we have to avoid nitrous oxide because it will lead to dilatation of the bowels. And ma'am, bang and mask should not be done because again it will lead to the dilatation of the bowel. And
how does it matter to us if the bowel is inflated?
Ma'am, it will further increase. It will further put load on the pulmonary hypoplasia, and it can also lead to pneumothorax. So that can be a problem. And we have to.
Why are we worried about mediastinal shift always? Why do we worry about tension, pneumothorax, mediastinal shift? Why do we worry about these things?
Ma'am, it will lead to sudden fall in BP, fall in heart rate.
Why does it lead to fall in BP?
Ma'am, because
anybody mediastinal shift, why does it lead to fall in BP?
Ma'am, there is effect on the heart, ma'am. The heart cannot pump effectively and a fall in cardiac
arrest. Not pump effectively, yeah?
Ma'am, there's a
cardium is not so that you get compressed, no? What is
ma'am,
ma'am, compression of the IVC.
Forget about a neonate. Tell me mediastinal shift.
IVC compression.
IVC compression. Okay? There is no preload to the heart. Okay? Okay.
Yes, ma'am.
This is how tension works. Okay. So Ira was saying that we will pre-oxygenate. We will not. We will induce either with maybe thio or sevoflurane. We will avoid nitrous, and we will do a rapid sequence induction. We will minimize bypass ventilation, and then we will intubate. Ira, what is your target once you intubate?
Ma'am, ma'am, the ventilatory targets.
Yes.
Okay, ma'am. Ma'am, we have to go for a protective ventilation.
Yes.
So in that, ma'am, we'll use small tidal volume. Our peak inspiratory pressure should be equal to or less than 25. Our PEEP should be 3 to 5 centimeter water. We will allow permissive hypercapnia, 60 to 65 mmHg. pH should be more than 7.25, and preductal saturation should.
Thing is, what is this? I know you're talking about saturation now. This retinopathy of prematurity. Should we worry about that? Because suppose we are not able to maintain the saturation till we give 100% FiO2.
More than 85.
Whatever. Intraop it is targeted at 95. Whatever, you tell me that if we are not able to achieve less than with 100%, should we worry?
Ma'am, it means that the
random question in the middle of this topic, but I've just asked.
Patient will go into it means that the saturation is low means that
I'm asking about retinopathy of prematurity.
Oh, sorry, ma'am. Sorry, ma'am.
Can we give Anyway, doesn't matter. We can talk about that some other time. Actually, the risk of ROP is till the baby is about 50 weeks gestation. Okay, so in neonate, that possibility is always there. Okay, so you have to keep that in mind. Now you're doing all this, you're doing a protective ventilation, you're maintaining an FiO2 and a SpO2 and a PaCO2, you're avoiding nitrous. Now patient is hemodynamically, suppose suddenly there is a fall in saturation.
Yes, ma'am.
What are you going to do? And what is the
Ma'am, first of all, on the ipsilateral lung, there must be a chest tube already. So most probably the pneumothorax would have occurred. So on the contralateral side, we'll put a chest tube, and then we'll check. If it's still not correct, then most probably IVC compression has occurred, or there is, or because the abdomen was scaphoid and all the organs were placed inside, so it must be pushing the diaphragm upward, because of which the pulmonary compliance must have decreased. So in that case, we'll open the wound, and we let the IVC.
And then also look out for right to left shunts. Okay, maybe the shunting has increased because of increase in PVR. Right now, so how do we decrease the right to left shunt?
Ma'am, post-op. Ma'am, pardon. Intra-op, yes, ma'am.
Suppose I told you the SpO2 has fallen, you gave a lot of reasons why.
Yes, ma'am.
The one is closed, maybe there's a bilateral pneumothorax. But another reason I said it can also be because of accelerated increase in PVR or causing an increased right to left shunt, right? From the PDA.
Yes, ma'am. Yes,
So
ma'am.
how do you prevent that? Again, by preventing hypoxia, hypercarbia,
Hypoxia.
hypothermia.
Yes, ma'am. All the reasons like.
Anesthesia.
Yes, ma'am. All the reasons which increase the PVR, like pain, hypercarbia, hypoxemia, hypoglycemia, and hypothermia.
Yes, good. Now, if the patient is stable from preoperatively, then most likely a lot of them get extubated on table. But if they are not extubatable, then what care do you take in the post-op period?
Ma'am, we'll shift what care we'll take in the ma'am, the patient will be intubated, and we'll give adequate sedation to the patient. We have to take care of that the gas exchange is fine, compliance is fine, so we'll take EBGs and monitor that, and we have to take care that the pulmonary hypertension is not present, and if needed, we'll keep the patient on. Yes,
same
ma'am.
Protective ventilation. Same protective ventilation.
Protective ventilation.
Keep
Okay,
the
ma'am.
air pressures low, lowest possible FiO2, right? Sedation,
Yes, ma'am.
anesthesia, maintain temperatures, fluid electrolytes.
Anesthesia.
Okay. So what are the post-op complications in these patients?
Ma'am, in these. Yes, ma'am.
Late onset, late.
Long-term, yes, ma'am. Long-term complications have been seen, like recurrent respiratory tract infection and chest deformity might be there. GERD might be there. Failure to thrive, sensory neural hearing loss, and cognitive impairment, muscular abnormalities like scoliosis or pectus excavatum.
Yeah.
Delayed growth.
Now, I think that about concludes CTH. Does anybody have any questions? Because I just want to tell you guys that you have suffered a lot. You fought very bravely in COVID. That's why I don't feel like saying much to you. But you people have lost 1.5 years of regular training. And frankly, this is not the way to cope with it. That out of how many, there are only 20 kids here, and out of them only 2 people have read. Neither is that encouraging for the person like instructor who has worked hard to come and take this class for you, and it doesn't help you in any which way. You people have suffered because of lack of routine OT, and you're not helping yourselves. So please help yourself by, and even if you go for exam-oriented studies, pehle hota tha that you don't have to read neonates because you don't get neonates. But now they are virtual cases, you can get anything. So you have to read everything. I'm there for help in OT anytime anybody wants to discuss these cases. I'm there. But unless you help yourselves, who is going to help you, right? It begins with self-help. Please, all of you start reading. This has not been a very encouraging class as far as I'm concerned. Any questions? Okay. Thank you, Ira. Thank you, Hemlata. Okay.
Thank you.
Thank you. Thank you.
Thank you, ma'am. Thank you, ma'am.